So we're now going to look at the individual endocrine glands and what they do. We're going to begin with hypothalamus, and that will lead us directly into pituitary gland because these two are very, very closely related to each other. So hypothalamus, if you recall where that is or what that looks like, hopefully you got to look at the visible body at this point. And if not, you'll get to that and you'll see that it's that area above the pituitary gland. So hypothalamus is this whole area right here, okay? Whenever you have a labeling exercise, if I'm asking you to label something on the exam, you might see this figure, it just won't have the words, right? So if you have a line that points to this and it's asking you to identify this, you would tell me hypothalamus, right? This is the area that this is pointing to. So we see hypothalamus and the pituitary gland, and we have two different images here. The top one is focusing on the hypothalamus and its relationship to the posterior pituitary, and then the bottom one is more focusing on anterior pituitary here. Hypothalamus releases several different hormones. It releases two hormones that are going to be directly passing into the posterior pituitary, and these are called oxytocin and antidiuretic hormone. As we can see from this figure, oxytocin is produced in paraventricular nucleus, and ADH is produced in supraoptic nucleus. And these are just regions of the hypothalamus that have a concentration of cells that produce these hormones. The posterior pituitary is this part of the pituitary right here, okay? It's this, it looks kind of like a punching bag if you look at that. So that's how I remember that posterior pituitary looks like a punching bag. And then the anterior pituitary is that other part, and the anterior pituitary kind of looks like it's just attached to the posterior pituitary at that neck. So you have like your neck of the posterior pituitary, and you have that attachment kind of just wrapping around it like that. That part that's wrapping around that infundibulum is called pars tubularis. And those are, you're supposed to label those on visible body, and you might have to kind of play around a little bit and go over the anatomy ID several times with that. So the anterior pituitary looks like it's attached at that neck by using that pars tubularis, and so I remember anterior looks like it's attached, okay? It's not as visible on visible body as it is right here on this picture right here. So posterior pituitary is that punching bag like looking thing, and we also call posterior pituitary neurohypophysis. Because it has it uses neurons basically. It has all these axons that are going from those nuclei up here, and they run through the infundibulum, and the ends of the axons are in the pars nervosa. Okay, so this part, this rounded part, is the pars nervosa. It's a little delayed on your end right there as I'm drawing this. Okay, a little more anatomy here, some anatomical terms here. The neck of the posterior pituitary, this is called infundibulum. It's a very fun word, I think. So infundibulum, and then inside of that infundibulum, you see that those axons are running through there, right? And so those yellow and green lines together, okay, that bundle of axons, this is called hypothalamo-hypophyseal tract. Okay, hypothalamo-hypophyseal tract, and it's inside of the infundibulum. So that's that. Now, hypothalamus, when it produces this oxytocin and ADH, it releases them and basically passes them along those axons to the pars nervosa of the posterior pituitary. From here, then they are released if hypothalamus gives a signal to the posterior pituitary and tells it, okay, we need oxytocin, we need ADH, release them. Posterior pituitary will release them. And that's that. So that's actually it for posterior pituitary also. but we're not done with hypothalamus yet. Okay, so posterior pituitary does not produce any hormones. It only receives the oxytocin and ADH from the hypothalamus, and then it releases them when it's stimulated to do so. Okay, so that's our posterior pituitary. Now, focusing more on that bottom image here, you see more of an anterior pituitary stuff going on here, and we don't see a whole lot of hypothalamus here. But hypothalamus is still a very important message signaling to the anterior pituitary. The way anterior pituitary and hypothalamus communicate with each other is through this hypothalamo-hypophyseal portal system. Okay, so this is the system of those blood vessels that you see here. So we see this network of capillaries right here, and we call that primary plexus. Okay, so it's the first capillary bed that we have here. And this is where hormones from the hypothalamus are going to enter the bloodstream, and then all this blood is going to eventually be directed into the portal veins. And then the portal veins, they're not very long. This is a very small structure. But those portal veins then branch out into another capillary bed. We call that a secondary plexus. This one is wrapping this pars distalis of the anterior pituitary. So this part of the anterior pituitary is called the pars distalis. I've already mentioned that this part that wraps around that infundibulum is pars tubellaris, right? And then here in the middle is the pars intermedia right there. So we have a bunch of these capillaries in the primary plexus, right? The more capillaries you have, the more places you have for the hormone to enter the bloodstream. And so think about them as a bunch of little country roads. And then ultimately those country roads will come together into a highway, which would be our portal veins. And then you're trying to distribute this to places, right? So then we would see branching into the secondary plexus so that the unloading of the hormone is more efficient. So this is actually a first portal system that we're seeing. Here we will be talking about another portal system when we talk about digestive system, and that's going to be the hepatic portal system. Actually, we will see it in the blood vessels chapter there as well. Where you have all the capillaries from the digestive system collecting nutrients, and then that blood is going to ultimately be led to hepatic portal vein, and then hepatic portal vein goes towards the liver, and in the liver it spreads through the liver again into ultimately capillaries. So you have two large capillary beds there. But this is our first portal system that we're talking about. Now, when you look at this is actually missing something here at the top. There's one hormone that for some reason they forgot to put here, and that is, this is very thick. Oh no. Okay, let me adjust the thickness of my pen here and get rid of this. Okay, so we should have in this top pink box, there should be growth hormone inhibiting hormone. I'm just going to write IH, but that stands for inhibiting hormone. It's missing from this table for some reason. So this box summarizes all the releasing hormones that the hypothalamus releases. Okay, so we have our thyrotropin releasing hormone. There's prolactin releasing hormone. That one has an opposite also. There's a prolactin inhibiting hormone as well. So that's not a releasing hormone, that's inhibiting. Then we have gonadotropin releasing hormone, corticotropin releasing hormone, and growth hormone releasing hormone. Okay, all of these are going to release some other hormone, and where are they going to release it from? Anterior pituitary. That's why they're written in this box right here. Okay, so all of these releasing, there are 5 releasing hormones. Okay, you can count them and see how many of them have RH. Okay, and in the end, or releasing hormone, the 2 words. There are 5 releasing hormones. There are 2 inhibiting hormones, and those are growth hormone inhibiting hormone and prolactin inhibiting hormone. Those also act on the anterior pituitary, and they inhibit release of those hormones. Okay, that they inhibit. So this table kind of like, it shows you what anterior pituitary does as a response to those releasing hormones. However, it doesn't tell you which hormone caused that. And so for that reason, what I want you to, no, okay, hold on. I thought that was just going to get me, all right, let me see how I can share. And I have recorded a video for you about the lab exercises, okay? So whenever you're studying, and this, you should be filling this out as you're studying, okay? This is not an extra thing, really. It's supposed to guide you through your reading. So whenever you're, you know, you're reading and you get to this section, okay? And even if you have read it already, that's fine. Just revisit this table here. What you're supposed to do here is you're supposed to list all those releasing hormones in here, okay? I said there's 5 of those releasing hormones. That's where they go. And so if, and I, you know, actually, I'm not gonna go ahead and repeat it. Watch that video that I attached to that. It's attached to that endocrine lab exercise, okay? And it tells you what I want you to put where here. But anyway, so this table will summarize the hypothalamus and the pituitary for you, okay? So going back to this right here, the thyrotropin releasing hormone, this one is going to cause release of thyroid stimulating hormone from anterior pituitary. And actually, when we switch to this view right here, this one does show you the pathways of what releases what. Okay, so this is a very useful figure here. And here we do have that growth hormone inhibiting hormone. See, they included it right here at the bottom, but it wasn't on the previous table. Oh well. And so consult this table or this figure as well as the previous one to help you fill out that endocrine system table, okay? That is what will kind of show you the flow of every single hormone there, okay? So anterior pituitary releases thyroid stimulating hormone, it releases prolactin, and in those first 5 where it has releasing hormones, that in the function in the last column, that's where you will write the function of the anterior pituitary hormone. But again, I explained that on that other video for you. So the anterior pituitary actually releases one other hormone that is not on here. It might be somewhere in your textbook unless they took it out, but that's melanocyte stimulating hormone. And this one is not very not important, but not very active in adults or in humans, really. It gets slightly activated during pregnancy when women experience like darkening of areolas or the line that forms on their abdomen. So that's because of that hormone. But other than that, it doesn't have a huge effect in our body. And it's not really stimulated by hypothalamus, okay? So it's not in this table, okay? So let's go ahead. So for every gland, we're going to have a representative hormone, okay? And so now we talked about the hypothalamic hormones, okay? We'll actually talk about ADH and oxytocin more in detail later. So we're not picking a representative hormone from hypothalamus. We're picking a representative hormone from the anterior pituitary here. The hormone that we are picking is the growth hormone. And so every hormone is going to have a table that looks like this, where you begin with the stimulus at the top, and then it tells you where it goes, what it does, and what is the effect. And that's at the bottom, you see the effectors. That is describing to you what did that hormone do? What was its final effect? And so for growth hormone, there are various stimuli that can release the growth hormone releasing hormone from hypothalamus, because it's the hypothalamus that gets that stimulus and initiates that pathway. So time of the day and age are big ones. Also, nutrient levels in your blood are a stimulus for release of growth hormone releasing hormone. negative feedback and stress and exercise are also going to stimulate release of growth hormone releasing hormone. So hypothalamus responds to one of these stimuli, and it will then release growth hormone releasing hormone. Growth hormone releasing hormone will then act on the anterior pituitary, and it will tell it to release growth hormone. Okay. Now, growth hormone is going to go to one of two places. It can directly go into the blood, and so some of that growth hormone directly enters the blood and does its job. Okay, and its job in general is to increase growth. But some of that growth hormone will be directed towards the liver, and in the liver, this growth hormone will stimulate the release of insulin-like growth factor. And these two, growth hormone and insulin-like growth factor, have the same function. They both have the same end result that we see here at the bottom. The difference between these two is that growth hormone has a fairly short half-life. It's in minutes. It's less than 20 minutes, anywhere between 6 to 20 minutes. And half-life means that, or a short half-life means that it's being used or broken down fairly quickly by your body. Insulin-like growth factor has a much longer half-life. So it stays around longer, stays around for about 20 hours. So we go from, there's the differences between minutes and hours, okay? So insulin-like growth factor does its job, supports this growth or promotes growth of tissues for a longer period of time. When you look at the bottom here, we see that bone and muscle is stimulated to grow. You also see glycogenolysis and increasing, and lipolysis increasing. So this means that we're breaking down glycogen, which glycogen serves as a storage of glucose, right? So we're breaking it down. We're also breaking down lipids into glycerol and fatty acids. And so this makes sense, because if your body is experiencing increased growth, you need nutrients to fuel this, right? And so all these nutrients are taken from storage, and they're broken down into small molecules so that your body can use this for energy, and it can promote this growth, okay? And for that reason, you would see opposite, you would see decreased glycogenesis, and you would see decrease lipogenesis, okay? You would see decrease in storing these, since you're releasing them into the blood, right? And so that's growth hormone. Now, when I mentioned stress and exercise promotes growth hormone releasing hormone, what I meant by that, because sometimes when people say stress, you know, you're probably, this is just a second day. Hold on, my computer just did something crazy. But we're, you know, we are stressed. Hopefully you're not stressed too much. How do I get this away? Okay, here we go. When I say stress promotes release of growth hormone releasing hormone, I don't just mean like emotional stress or psychological stress. We mean stress on the body. So it says stress on exercise there, right? So exercise is stress on your body. Injury, surgery, all that is stress on your body, okay? And as your body is trying to recover from that, repair tissue, this is going to need growth hormone for that reason. Age is a stimulus, so there's, if we look at this, this shows you the differences or different levels of growth hormone in different age groups. So when you look at it like a 5-year-old, they have a high level of growth hormone, and that is understandable. Their bodies are going through very, very rapid growth. And because their growth hormone levels are so high, this is also why young individuals, young kids, recover from injuries or surgeries faster than older individuals. Okay, that growth hormone helps with the repair. And then as we age, it decreases. The bottom table shows you the fluctuations of the growth hormone in throughout the day. So you can see that your growth hormone level stays pretty steady from about 3 o'clock in the morning until about 4 p.m. That's the 16th. And then in the afternoon, it begins to increase. Okay, it peaks somewhere around 11 o'clock. And and then decreases, okay? This is because your body takes time to repair and grow at night, okay? During the day, you're busy with other things. You're busy with walking, talking, thinking, eating, digesting. There's a lot of different things that your body does during the day. And so growth and repair is not really on the priority list when you're doing other things. But when you sleep is when your body recovers the best, okay? Remember that saying, sleep is the best doctor, okay? And that also allows your immune system to work better. And I say that most of this stuff happens at night, but yet we see decrease, kind of fairly early at night, right? 11 o'clock. And that's because, remember, growth hormone also promotes release of insulin-like growth factor. So that one is going to be released, and it's going to be doing the job for the rest of the night throughout, about 4 o'clock-ish, when growth hormone starts going up again. This is what the curve would look like for a person that is on a normal schedule. You wake up in the morning, you go to bed at night. People that have flipped schedules would actually have this different for them. So my father-in-law used to work for American Airlines, and he used to work night shifts. So his wouldn't look like this because he slept during the day. So, but this is for regular, get up in the morning, go to bed at night. And then with the stress, I mentioned that, stress, it includes all kinds of stress, but it's been actually shown that increased stress, psychological or emotional stress in children actually decreases that growth hormone for them. And so children that are going through severe emotional stress might experience stunted growth. Okay. So that is growth hormone. Now this picture shows you some issues with the growth hormone release. So you see a woman with acromegaly. Acromegaly is a disorder of the pituitary gland when it doesn't release the growth hormone correctly. It is not the same as gigantism. Gigantism affects the whole person and everything is bigger. Acromegaly usually doesn't present until about like somewhere in the mid-20s and later. You can see this woman with acromegaly at age 20. You couldn't really see a lot of symptoms, but then as she aged, acromegaly affects your facial bones, so your nose and your cheek bones grow faster, and then your hands and feet, but not the other bones. If you remember Andre the Giant, he had acromegaly. And then gigantism affects the whole person, as I said. And then there's a picture of a person with pituitary dwarfism. So this is where pituitary is not releasing enough of that growth hormone, and it results in this condition. And this is discussed in the clinical view in the textbook, so you can have a look at that there. All right, let's talk about the thyroid gland. Thyroid gland is a bilobed gland. It is located right here. So you can kind of touch your throat and try to locate where it is. And if you actually put your fingers in this area and you swallow, you should be able to feel the thyroid gland move up and down, okay, when you swallow. It is a bilobed gland. It has left and right lobe, and then the middle region is called isthmus. Okay, so this area, oops, now I need a thicker, okay, this area right here, that's called the isthmus. That's what connects the two lobes. Thyroid gland is internally organized into like follicular cells and parafollicular cells. There's no cortex or medulla, no anterior posterior. It's just left and right lobe. And then throughout the whole gland, it would look like this under the microscope, okay? So it looks kind of like bubbles, right? Maybe this different color right here. So these look like bubbles. They're not bubbles. They are called follicles. And the cells, you can see that they're created from a single row of cells there. These cells are called follicular cells because they create the follicle. Inside of the follicle is colloid fluid, And in this colloid is where the thyroid hormone gets produced. So this is where it's being cooked. Okay? It's not really cooked, but that's where it is being formed. Then between the follicles, here and there, you have some parafollicular cells. So like right here, you can see them, or right here, just cells that are not part of the follicle are called parafollicular cells, and these release calcitonin from the thyroid gland. So there are 3 spots in the table in the lab manual sheet for hormones from thyroid gland, and so one would be T4, one would be T3, and one would be calcitonin, right? T3 and T4 come from the follicular cells. Calcitonin comes from the parafollicular cells. Okay, if you forget that, come back to the recording. So let's look a little bit about how the thyroid hormone is being produced. One important thing that I want you to remember about thyroid hormone is, well, actually a couple important things. First, it's the only biogenic amine that's lipid soluble. Okay, remember that's the exception to the biogenic amines. And then the second thing is that without iodine, your body cannot create thyroid hormone. Okay, so you absolutely need to have iodine in your blood and in your diet to be able to form thyroid hormone. The number of iodines that actually end up on the final molecule of the thyroid hormone determine whether the hormone is T3 or T4. So if it's T4, it has 4 iodines. If it's T3, it has only 3 iodines. Okay. As far as the formation of it, okay, you can see that the precursors are made by the Golgi, or well, rough endoplasmic reticulum, then goes through Golgi, and then those precursors enter the colloid here. At the same time, iodine is being taken from the blood and passed through those follicular cells into the colloid. In the colloid, those precursor molecules will bind to the iodines, and once they do so, they are going to return back to the follicular cells. They are going to be finally modified into the final T3 and T4 hormones, and then they're released into the blood. Okay. The T3 is more active, but your body actually forms more T4. So a lot of your cells, many cells before they use thyroid hormone, they're going to basically chop off one of those iodines and convert that T3 into T4. I just said that backwards. It will convert T4 into T3, right? Because you're removing one iodine. The thyroid hormone, as far and you don't need to be able to describe this, okay, but that just kind of shows you where those iodines are going. The thyroid hormone is released from the thyroid gland as a response to the message from the anterior pituitary. So the whole cascade begins actually with the hypothalamus, where hypothalamus releases thyrotropin releasing hormone. It releases this thyrotropin releasing hormone based on many stimuli. Cold weather can be one, pregnancy, decreased thyroid hormone, so negative feedback there. What else? High altitude, I forgot, as well as hypoglycemia are stimuli for thyrotropin releasing hormone. Thyrotropin releasing hormone then will act on anterior pituitary. Anterior pituitary will release thyroid stimulating hormone, and thyroid stimulating hormone will then release thyroid hormone from thyroid gland. What the thyroid hormone does is, in general, it increases metabolic rate. Okay, so thyroid hormone causes increase of metabolic rate. So when you look at those stimuli there, that makes sense, right? Cold weather. If you increase metabolic rate, you're also going to cause your body to produce more heat, because metabolic rate is associated with heat. So we say that thyroid hormone has calorigenic effect. Calor means heat in Spanish. And so I don't know if it means heat in other languages, but I know in Spanish it does. And so it has calorigenic effect. It generates heat, right? And so that's that's that. What else? Pregnancy. The woman's body is in overdrive. It is working hard. It's growing a new human, and so metabolic rate will be higher. So thyroid hormone will be higher. High altitude is going to have with the other effects that the thyroid hormone has, which you can see right here. And that is that thyroid hormone is going to increase the rate of breathing. So your respiratory rate goes up, your heart rate goes up, as well as force of contraction goes up. So if your body is experiencing increased metabolic rate, you have to be able to fuel this process. Okay, so you would see release of nutrients into the blood. You also want to make sure that you're circulating those nutrients through the blood faster to increase them, to fuel that increased metabolic rate. And so that's where the increase heart rate is coming from, as well as the force of contraction. And the increased metabolic rate means the increased rate of cellular respiration. So that's where your increased respiratory rate comes into play. Okay. And so if you're in high altitude, you would be experiencing low oxygen conditions. And so your thyroid hormone would be stimulated to increase respiratory rate and force of contraction to take in more oxygen and move it through your body faster. So that's the thyroid hormone. If you look at these are images from the clinical view. So you can kind of, this is exothalamus, and this is goiter. Goiter is, this is basically the thyroid gland that has grown. So this is usually occurring in individuals that don't have enough iodine in their diet. So they're iodine deficient. Or it could also happen to people that have some kind of a problem with the thyroid hormone synthesis. That's other than nutritional one, because that happens too sometimes. Yeah, if your body does not have iodine, your body cannot create thyroid hormone. And so what's happening is, remember, low thyroid hormone is one of the stimuli for the thyrotropin releasing hormone from hypothalamus. And so if you have low levels or no levels of thyroid hormone, your hypothalamus takes that as a stimulus. And so it keeps releasing thyrotropin releasing hormone. That is telling the anterior pituitary, hey, we need more thyroid hormone, release thyroid stimulating hormone. Anterior pituitary does so. Thyroid stimulating hormone goes to the thyroid gland, but thyroid gland doesn't have the iodine. It doesn't have the necessary ingredient. And so it's not working. So then hypothalamus keeps releasing more of that releasing hormone, the thyrotropin releasing hormone. Anterior pituitary is like, I'm sending the message, so it just keeps sending the message more and more to the thyroid gland, and thyroid gland is trying to do this process, but it can't because it doesn't have the ingredient. So it starts growing, almost like trying to accommodate the demand for the thyroid hormone by enlarging itself. Of course, that's not gonna work, because if you don't have the ingredient, it won't be able to make it. But goiter, it doesn't go away if you do replenish the iodine into the diet. It has to be surgically shrunk again to a normal size. So anyways, that's the thyroid gland. And we have our last two are adrenal gland and pancreas. So we're almost there. I hope this recording doesn't time out on me. I don't have a timer. So let's go ahead and talk about the adrenal gland. Adrenal gland, these are a pair of glands. So there's one gland on each kidney, on each superior surface of the kidney. They're also known as the suprarenal glands. That's another word for them. Adrenal glands are divided into cortex and medulla, and cortex is then further subdivided into zonas. Okay, for your exam, I do want you to know this division, or well, the whole thing. Okay, this division. on both the drawing and the microscope slide next to it, okay? So know the order of the zonas and know what each zona does. So be able to match hormones that come from each zone with the zone. And there is also in that lab exercise, you have a table where you can fill this in. So adrenal glands have a capsule. It's a pretty fatty capsule, so it has kind of a yellowish appearance for that reason. And then the cortex is divided into those three zonas. The three zonas are the zona glomerulosa, that's the one right underneath the capsule. The zona glomerulosa is going to secrete mineral corticoids. The most important mineral corticoid is going to be aldosterone. We will talk about aldosterone again in chapter 20, 19, one of those. So that's zona glomerulosa. Zona fasciculata is that middle layer. It is the longest layer, and the cells in this zone look like they're kind of arranged in rows, whereas the zona glomerulosa was kind of more like little blobs, okay? That's very scientific, right? Blobs and rows. But that's kind of what it looks like. The zona fasciculata secretes cortisol, and this is your main glucocorticoid. So zona fasciculata secretes glucocorticoids, and the main one is cortisol. And then the zona reticularis secretes secretes gonadocorticoids, and most of these will become androgens that will become testosterone. Okay, so that's why this group of hormones are called gonadocorticoids. And then we have the medulla. So this is, you know, like here you're looking at, it's like this rectangle enlarged, right? That's how you're looking at this figure. And adrenal medulla secretes epinephrine and norepinephrine, and these have been discussed in the nervous system already, so we're not going to talk about those. The representative hormone for the adrenal gland is going to be the cortisol, since it's our main glucocorticoid, and it's actually 95% of all glucocorticoids is cortisol. And here's our flow chart for cortisol action. So when we look at what the stimulus is for cortisol, it would be stress or time of the day, also the negative feedback by cortisol. So that's what causes hypothalamus to release corticotropin releasing hormone, okay? Corticotropin releasing hormone then acts on the anterior pituitary and tells the anterior pituitary to release adrenocorticotropic hormone. And this one then finally acts on the adrenal gland and tells the adrenal gland to release cortisol from the adrenal gland. As you can see, the net effects, we're going to have, our net effect is the increase of all nutrients in the bloodstream. Okay, so it has an effect of releasing nutrients into the blood. We're going to see we're going to see actually gluconeogenesis. We're going to see uptake of amino acids by the liver, and then this liver is going to convert it into glucose to just increase glucose even more past the normal glycogenolysis. And you see lipolysis increase, since we're increasing amount of nutrients in the blood, and you know, breakdown of proteins so that amino acids are released into the blood. Okay, that's the main function of cortisol. Now, we use corticosteroid treatments, corticosteroids, for a lot of for treating a lot of different conditions, because it actually corticosteroids actually inhibit inflammation. So we use it to treat chronic inflammatory diseases. They're usually corticosteroids. However, overuse of these corticosteroids can lead to certain issues, such as retention of salt. If your body retains salt, you're also retaining water. Okay, so that's a relationship that I want you to remember from now on. Okay, wherever salt goes, wherever sodium goes, water is going to follow the sodium. Okay, and so if you're retaining salt, you're retaining water as well. It does decrease inflammation. So if you're treating a chronic inflammatory condition, this is good. You want that. However, if if something is going on in your body where inflammation is necessary, because inflammation normally is an immune response, and that's how it's a non-specific immune response. So you kind of slow down the process of recovery if it's a regular inflammation, if it's not that inflammatory disease that we're talking about. The high levels of cortisol also suppress the immune system. So these corticosteroid drugs also have an effect on your immune system, and then they inhibit connective tissue repair. So that's that. You can look at cortisol release throughout the day right here. Come on, switch. Okay, here we go. And so you can see how it fluctuates. It actually is kind of low when you go to bed, but then it goes up as you sleep. So towards the morning, your cortisol is higher because you're not, you're asleep, you're not digesting. So the levels of nutrients as your cells are using them, they're going down. So cortisol is acting on the storages of nutrients and releasing them into the blood, so it increases the nutrients as well. So that's cortisol. Now this is okay, switch. It's a little slow for me. But once this switches, I have a picture from the clinical view here, and this is a woman that has started treatment with corticosteroids. This is on the left side, you see her before she started treatment, and then on the right side, you can see after, what she looks like after. And this is not necessarily, corticosteroids do affect your weight a little bit, but this is also affecting the amount of water that she is retaining. So it's not all just increased fat, but it's also water. It's so she developed Cushing disease or Cushing syndrome, which is very characteristic by developing this moon face, as you can observe here. And also often people will develop a hump on their back. So that's one risk of a long use of corticosteroids. You just kind of have to evaluate, whether you want to suffer the chronic inflammation or be at risk for this. So, and this is a stressed person. Hopefully you're not looking like this right now. We're almost done. Pancreas is the last one, and pancreas is not very, very long here. A pancreas is an elongated organ. It has head, body, and tail parts. These parts have the same function. So you have the head right here, body, and then tail is that pointy part. It's basically between the duodenum and the spleen. Pancreas is a heterocrine gland. So what this means is that it has both endocrine and exocrine functions. And the endocrine functions involve release of insulin and glucagon, and they involve pancreatic islets. Exocrine function are going to be associated with pancreatic acini, and these are going to be producing pancreatic juices that are going to be then collected by this duct that you see, I have yellow, that you see here. Okay, and that's going to go into duodenum, and it's going to help with digestion. Okay, and that's the exocrine part. When you look at the histology slide of the pancreas here, this lighter colored area, that's a pancreatic islet. All these these small kind of round clusters of darker cells here, these darker clusters, those are the pancreatic acini. And pancreatic acini, again, are the exocrine parts. Pancreatic islets are the endocrine parts, and most of the pancreas is actually exocrine. Okay, and on the slides, if we actually were in the lab, you might, there are some slides that we have where you cannot see the islets at all. I uploaded a file with histology pictures for you, and on that pancreas picture, you can see like 3 good pancreatic islets on there. I didn't label those because I want you to figure out where they are. But yeah, so that's that. Now the endocrine part of the pancreas, again, comes from those pancreatic islets, and there are several different types of cells that we see in the pancreatic islets. Alpha and beta cells are the ones that are important to us for the insulin and glucagon, and then there are also beta cells and delta cells and F cells. the alpha cells are going to secrete glucagon, and beta cells are the ones that secrete insulin. The insulin is released following a meal. So after you eat something, your digestive system is absorbing nutrients into the blood, and so the levels of nutrients rise. Insulin comes and is released by the pancreas by humoral stimulation. Remember humoral stimulation? Humoral stimulation responds to the levels of something in your blood. Okay, so in this case, we're responding to increasing levels of nutrients. Okay, so it's a humoral stimulation causes pancreas to release insulin. Insulin then does one of two things. Okay, well, actually, it does two things at the same time. Insulin causes linking of glucose molecules into longer chains of glycogen, and then this glycogen will be stored in the liver until it's needed to be chopped up again into glucose. And then the other thing that the insulin does is it serves as kind of a link between glucose and the cell that needs to use that glucose. So without insulin, your cells would not be able to use and utilize glucose into them. So somebody that has diabetes and that they don't have functioning beta cells, they following a meal, if they don't have insulin, their cells are starving. Their blood is full of glucose, so they would have high levels of glucose, yet the cells are hungry. They cannot use that glucose for energy. Okay, so those are beta cells and insulin, and then alpha cells secrete glucagon. Glucagon has the opposite effect, where it causes the release of glycogen and chopping down the glycogen into individual glucose molecules, and that increases levels of nutrients in your blood. So that you're not too low or too high in nutrients. Yeah, so that's a pancreas, and that's the last gland that we really will discuss in detail. There's some other ones like pineal gland. We're not really going, and here's a flow chart of that. I guess I forgot that we had one for that. But there are some other glands, like pineal gland secretes melatonin. Melatonin is going to affect your circadian rhythm. And some other ones that are listed that we will talk about later, like it talks a little bit about heart, and the heart releases atrial natriuretic peptide. I don't remember I don't have my book in front of me, but there's some other ones like ovaries and testes, what hormones they release, and some other ones. But we will talk about all of them except for skin and adipose tissue later. So just know like the representative hormone, but we'll discuss them in detail later. And then the very last part of this chapter is endocrine system and age. And basically the whole gist of that section is that as we age, nothing works as good anymore. So everything kind of starts breaking down as our body ages. So our hormones are not as effective as they once were. You saw with the growth hormone that as we age, the levels of growth hormone decrease. Levels of a lot of the hormone, most of the hormones will slowly decrease over our lifespan. So everything is just not working as efficiently as when we're younger. And so that concludes chapter 17. I will, if you're watching this on Tuesday, then I will see you tomorrow on Wednesday at 2 o'clock. If you're watching this from recording, then disregard that message. And have a great rest of the day, and I'll see you later.